It's my pleasure to introduce to you Chiara Pawela, and she will be discussing the cognitive changes and memory rehabilitation after stroke. And again, this is another issue that's been brought up on a number of occasions as we speak, as we've held these conferences. So Chiara is an endorsed clinical neuropsychologist, currently working across inpatient and outpatient medical psychology services at Westmead Hospital. She has previously worked across a number of acute, subacute and outpatient hospital settings within New South Wales Health, as well as in private practice, with her primary interest lying in acquired brain injury and rehabilitation. She is also affiliated with Macquarie University as an adjunct fellow and has research partnerships with Western Sydney University and teaches a postgraduate clinical neuropsychology and adult assessment subjects at Charles Sturt University. Now, when you hear all that, you'd think she was a much older lady than what she is. So I was quite shocked to see how lovely and young she is. So it's my pleasure now to introduce you to Chiara Pawela. Thank you.
Thanks again for having me. So I've got a lot that I'd like to talk about today. I've essentially crammed in roughly 30, 40 hours worth of talks into the next 50 minutes. So there are going to be some things that I do skim over a little bit because there are some more practical things that I do want to focus on a bit more. But if you've got any questions, please either ask them at the end or feel free to flick me an email as well. Before we get started, I do want to acknowledge some of the content has been inspired by the authors of the Making the Most of Your Memory program, as well as some of my wonderful ex-students who've put in a lot of work into adapting these slides. And also I know we had an acknowledgement of country earlier, but just to also pay my respects to the traditional owners of the land as well. Okay, excellent. So, like I said, quite a lot to cover today. We are going to do a bit of a Neuroanatomy 101 session before we get stuck into the memory stuff. I'm not going to give an overly comprehensive review of these things, but I think it is important to have an understanding of how the brain works and how memory works so that you can understand what to do about it. So, this is our brain. So when most people think about the brain, what we're really thinking about is the cerebrum. So that's all the bits in colour that we've got up there essentially. This is the biggest part of our brain and it's made up of two halves or two hemispheres. So we can only see one on this picture. Essentially what you're looking at is the brain from the left side on. So at the front of the red bit there, that's where our eyes are, and our ears sitting in front of that yellow bit as well, just to orient you. So our brain contains billions of neurons or nerve cells, and each of those neurons makes contact with thousands of other neurons throughout the brain. And this is how information is communicated throughout our brain. But the pattern and the strength of these connections constantly changes, and no two brains are alike. So it's within those changing connections that memories are stored, habits are formed, and personalities are shaped as well. And we do know that practicing memory tasks, for example, does increase some of those connections, and it can also increase the blood flow to certain parts of the brain as well. So, in order to understand what can happen cognitively when we have a stroke, firstly we need to have a bit of an understanding about what these different parts of the brain do. So I'll start off with the frontal lobe, so the biggest part of our brain, in the red there. So that's really important for things like personality, higher level executive functioning, those things like decision making, problem solving, goal-directed behaviour, and it also contains an area called Broca's area, which is important for speech production. Then behind that we've got the parietal lobe, so this essentially helps us to identify objects, understand spatial relationships, interpret touch, sensation and those sorts of things. And then behind it at the back in blue, we've got the occipital lobe, which is primarily involved in our vision and visual processing. And last but not least, we've got the temporal lobe down in the yellow there, which is important for language comprehension, auditory processing, and deep inside the temporal lobe as well. You can't see it from the outside, but deep in there, we've got something called the hippocampus, which is very important for storage of memories. We've also got there the cerebellum down the bottom there, which is important for coordinating movements, maintaining our posture and balance, and then below that we have the brain stem, so that's connected to our spinal cord, and that's essentially important for functions that are essential to keeping us alive, things like regulating our heart rate, breathing, swallowing, all those sorts of things. So, like I said as well, we've got two hemispheres in the brain. So you've possibly heard of some myths or online quizzes and things looking at whether you're a left brain person or a right brain person. As with many other myths, it's got its roots in, I guess, the truth, but it's definitely an oversimplification and exaggeration of what actually happens in the brain. So you're not a left brain or a right brain person, you've got both sides of your brain and you use them both, and they're important for everything we're doing, but they do slightly different things. So whilst the two hemispheres of the brain look fairly similar, they're nearly symmetrical in appearance, they do slightly different things, or different versions of things, essentially. So the lateralization of the brain, so that word up the top there, that's basically the tendency for some cognitive process to be more dominant in one hemisphere than the other. So as an example, let's say in terms of memory processing specifically, the left side of our brain is going to be processing memory for words and things that we've heard, whereas the right side of our brain is going to be processing memories for things that we've seen, so things like faces and spatial locations. There is a bit of a caveat to that. This is the case for the vast majority of people, but if there's any left-handers in the room, this might be a bit different for you. It's still the case for most left-handers, around 75%, but we do have a small percentage of left-handers, around 10% of them, who have a complete reversal of this structure. So you might find that if you are left-handed, you've had a left hemisphere stroke and you're not finding that it's the verbal side of things that's tricky, it's more the visual side. That might be because you've got a reversal of those functions here. But most people, it's laid out like this. So to complicate matters even further, not only do we have these different lobes of the brain which do different things, but then we've got different arteries in the brain which are supplying blood flow to the brain, and they don't quite correspond with those four lobes very neatly. So what this picture has got in it, we've got the four lobes still in there, but with an overlay in colour of the different arteries of the brain. It's a little bit hard to see, but essentially all of the orangey, brown, yellow stuff is the middle cerebral artery. So that's covering the frontal lobe, the temporal lobe, and the parietal lobes. At the back in the purple there, we've got the posterior cerebral artery, which is mainly supplying the occipital lobe, but still can come down to the temporal and parietal lobes. And then at the front in green, we've got the anterior cerebral artery. So that's predominantly covering the frontal lobes, but again, moving back into the temporal and parietal lobes as well. So just a quick recap, I'm sure we're all aware of what a stroke is, but a stroke happens when blood can't get to an area of the brain, either due to a blocked artery in an ischemic stroke, or if there's a burst artery in a hemorrhagic stroke. So we do tend to see that most strokes occur in the middle cerebral artery, which, as you can see, does cover quite a bit of the brain. So there can be a lot of different areas in the brain impacted. So following a stroke, it's estimated that around 2/3 of people do experience cognitive changes, but it's very variable in terms of what people do experience. One of the reasons for that is given the anatomical features of these arteries and all of their offshoots, people even having a stroke in one of those arteries, if it's in one of the different branches of that, they can end up experiencing things quite differently. So I'm not going to go through this in a lot of depth, but essentially the kinds of cognitive changes that you experience are going to be dependent on where you've had your stroke, how your brain was organised to begin with, if you're left-handed or right-handed, as well as what your pre-stroke strengths and weaknesses were and how all of those connections were arranged in your brain specifically. Is there a question? Oh, we're getting a microphone, that might be easier. There we go.
Change the roots.
I didn't hear the first part of your question, sorry. Would you mind repeating it? Sorry.
Left side, the brain root, the right side, different.
Alan, are you talking about how your left side was damaged and you're talking about rewiring for neuroplasticity?
Yes.
Yep. So what was your question, if you can do that?
How do it?
How to do it, yep. So we will get to that, definitely. But essentially what happens when some of those cells in your brain do die off because of that damage, some of the parts of your brain around them will try and pick up the slack, essentially. So that's why we do get that period of recovery immediately after a stroke. But for a lot of people, that might plateau because I guess those other parts of the brain around it, they've already got their own things to do. So even though they're trying to pick up that slack and do a bit extra for the parts that have been damaged, there's only so much that they can do. But we can still learn new skills and learn new ways of doing things, perhaps by using some of those other pathways which are still working well. So I guess learning to do the same things in a different way, using different parts of the brain. Does that answer your question? Excellent. And we will speak a little bit more about that soon. Okay. Like I said, I won't go into this in too much depth, but if you are interested in the specifics, there's a lot of fantastic tables breaking it down, not just by artery and hemisphere, but even by those specific offshoots. So even just Googling stroke syndromes by artery, there's a lot of great resources that come up. There's a great resource called Stroke Syndromes by Kaplan as well, which goes into this in a lot of depth. So if you are interested, those are great resources. So, recovery after stroke, and I have specifically put the word spontaneous in brackets here because I think it is really important to acknowledge that spontaneous recovery is different to the entire recovery journey. So when we're speaking about spontaneous recovery, we're speaking about what your brain is doing all by itself without you doing anything or doing any rehab necessarily. That's just what your brain is doing. And you've probably also heard that, you know, this spontaneous recovery process ends after 3 months, but it's really not that simple. And I think what a lot of people take away from that message is that after 3 months, that's it, you're done. If you're still having problems, you've got to deal with it. And, you know, that's that. And I think that's a very dangerous message because I think not only is it not necessarily true, but I think that can lead to a lot of, you know, difficulties with adjustment and with mood, and it can sort of take away that sense of hope as well. So when I'm speaking about spontaneous recovery now, this is just in terms of what your brain is doing all by itself. It's not the end of the story. So there is a lot of variability in this spontaneous recovery process. There's a lot of factors that influence this. There's things specific to the stroke itself, so the location of the stroke, the type of stroke, whether it was an infarct or a hemorrhagic stroke, the extent of the damage, all those sorts of things. So in ischemic stroke, we do tend to have this spontaneous recovery period of around 3 months. For hemorrhagic stroke, it's a little bit different. We do tend to see that it's a bit more protracted, up to around 8-9 months sometimes, but we do tend to see more pronounced recovery overall in that time frame as well. So it can take longer in a hemorrhagic stroke, I suppose, to reach a new baseline. But there's a lot of other things that can impact recovery as well, not just the stroke itself. Mood is a very big one. A lot of people following stroke do experience periods of low mood, and there's a complex interaction with mood and recovery, but we do tend to see that low mood in that acute stage can impede rehabilitation and recovery. But we do see that antidepressant use immediately after stroke can enhance that recovery process. So if that is something that you're struggling with, definitely speak to your doctors about whether or not that would be helpful for you. The type of treatment you get, the timing, the dose, all of those rehabilitation factors can make an impact as well. If possible, it is ideal to be engaging in rehab in those earlier stages and sort of give this spontaneous process a bit of a boost and a leg up and work with what your brain is already doing, but that's not to say that after that sort of 3-month period that you can't continue to engage in rehabilitation. There's also genetic factors, age, there are some sex differences, which can also impact recovery, and socioeconomic status too. So we do tend to see that people from lower SES groups, they do tend to have poor access to healthcare and rehab, so that can impact recovery as well. Caregiver support is a big one as well, so trying to involve your support networks in your rehab can make a big difference, as well as just your general understanding of stroke. So hopefully by the end of this presentation you have a little bit more of an understanding of stroke, and hopefully that's helpful. After this 3-month period though, like I said, that's not to say that you can't still continue to recover and continue to learn new skills. And so what we do tend to see in terms of memory rehabilitation specifically, while after this 3-month period we might not necessarily see massive changes on formal testing, for example, we do see big improvements in how people are coping and compensating for their memory difficulties, and that tends to have flow-on effects to things like quality of life and mood as well. So even if your memory itself doesn't get much better, you can learn different ways of remembering things and getting around those memory issues to make your life a lot easier. So just a bit of a side note for any professionals in the room or watching along online, we do know that the presence of cognitive changes in the acute stages of recovery are a really important predictor of recovery, but also it's important to be aware of someone's unique pattern of strengths and weaknesses so that we can support rehabilitation and make sure that we're tailoring rehabilitation to them. And so it is quite important to be assessing cognition whilst we're in those rehabilitation stages. But there's a few issues. We don't tend to do more comprehensive neuropsychological assessments in the acute stage, and it is primarily because of that spontaneous recovery period. If we do a really comprehensive assessment at 4 weeks post-stroke, by 8 weeks post-stroke, our results are probably going to be meaningless and be completely different. So we don't tend to put people through the ringer with our very long, lengthy assessments that early on. So teams do tend to resort to briefer cognitive screens instead. The problem with a lot of screens is that they're not appropriate for stroke. So they're not stroke specific. Most things like the MOCA, for example, the RUDAS, MMSE, all those sorts of things are developed for screening of dementia. They're heavily language dependent, which might not be appropriate for a lot of people with stroke if they have any aphasia. Visual neglect can also confound a lot of the tasks, and also more generally a lot of the cognitive domains that we know can be affected by stroke aren't tapped in any of those screens. They also take on quite a unitary view of cognition, so just, sort of pass, fail, do you meet the cutoff? And again, that's not very useful in stroke, and that's not very useful for guiding rehabilitation. So for anyone who does do cognitive screening, I would highly recommend that you have a look into the Oxford Cognitive Screen. This is developed specifically for stroke, for the acute and subacute stages. It's domain specific, so we don't get an overall score, we get scores within these 5 domains. And it includes specifically domains that we do know are more impacted by stroke. It's also aphasia friendly, so there's a lot of options for responding, and it's neglect friendly as well. It is available through New South Wales Health, through the ACI website. So if you do work for health, please have a look at what's up on the ACI website. There's training modules as well as all of the materials you'll need, and the protocols have been printed on all the standard New South Wales Health forms and things like that for use too. If you don't work for New South Wales Health, I believe all of the training modules are available on the Stroke Foundation's website as an alternative. So I think that's an important change to be making to clinical practice if you are doing cognitive screening. Okay, so in terms of how memory works. So again, it's important to know how memory works so that we know what to do about it. So when we think about memory, I think often we think about it as just this one sort of single process. We remember things or we don't, but there's a lot of different things that go into memory. So there's essentially 3 stages, and memory can fail when we have difficulties with any one or more of these stages. And the types of strategies that you might use and that are going to be most effective for you are going to depend on where in this process the breakdown is for you specifically. So it's good to try and reflect on where exactly you think the issues might be for you. So step 1, encoding. So this is taking the information in the first place. So if we think about it as a filing cabinet, this is putting the files in the filing cabinet in the first place. There are a lot of things that can impact encoding. Brain functioning or any structural changes due to stroke is just one of them. But even without having had a stroke, there's a lot of things that can feed into this and can impact our encoding. Our alertness levels, for one, are very important. I'm sure we've all experienced if we're feeling a bit more fatigued or haven't slept very well, it's going to be a lot harder for us to focus and take things in. And especially in stroke, as we've just heard, fatigue can be quite a significant issue for some people. So it is important to try and take things in that are important at a time that you think you're going to be most alert. Mood can also impact encoding, and again, this can be an issue for anyone, but also particularly in stroke. Low mood, stress, anxiety can all impact how well we can focus and take things in. But also our motivation. So I do tend to hear a lot that people say, if I'm interested in something, I can remember it a lot better, but if it's, long, complicated and boring, I just can't pay attention. And there are reasons for that. So when something is interesting or we like it, our brain does send a whole heap of dopamine to our frontal lobes, and that basically helps our frontal lobes to engage and attend to things. So our brains make it easier for us to focus on things that we like, and unfortunately we don't get that same neurotransmitter boost for things that are boring. Sensory abilities are also very important. If you haven't seen something properly or you haven't heard something properly, you're not going to remember it properly later on. So if you do need to get your hearing checked or your vision checked, that's definitely something worth pursuing because that can have flow-on effects to your memory as well. Underlying cognitive skills, so not just paying attention, but also similar to the sensory abilities. If we haven't understood something fully, if we haven't processed the visual information accurately, again, we're not going to accurately remember it later on. as well as our speed of processing, and this is quite commonly impacted in stroke. I'm not practicing what I preach right now, and I'm speaking quite fast to get through a lot of content, but in general, if you're getting a lot of information all at once, it can be a lot more difficult to process that properly, and some of those files might fall out of your file before they get into the filing cabinet. And strategy use as well. So there are a lot of strategies that we can use to assist in coding, which I will go through in a moment. So stage 2 is storage. So this is essentially just keeping things in the filing cabinet, making sure that they stick in there. This process actually begins just after a few moments. Once we've finished, holding the last sentence I've said in your head, your brain is already sending that off for storage as a long-term memory. So we often speak about short-term memory as, the last few days or weeks, but what your brain is actually doing, short-term memory is just a few seconds. Long-term memory processing is already starting beyond that. But this process can continue for a really long time. So it can continue for hours, days, even weeks, sometimes months. And it can be impacted by intervening events as well. Loss of consciousness is a big one, and that's why often when people do lose consciousness, they might not remember things for hours, days, even weeks before, depending on the severity of the brain injury. And that's because this storage process hasn't finished yet. So all of that information hasn't stuck in the brain properly yet. Alcohol is also a big one, so I'm sure no one in the room has ever drunk so much alcohol that they've blacked out, but if you've ever experienced that and wake up the next morning and can't remember much from the night before, that's because alcohol does selectively impact the hippocampus, so going back to deep inside our temporal lobe, and that's really important for storage. So basically that part of the brain just shuts down, and so even if you're encoding things okay, it's not going to be stored, it's not going to stick. Other interfering memories as well can impact this. So if we learn a lot of similar information all at once, that can get a bit hazy and the details might get lost. The good news is though, for the most part, it's less likely that storage is going to be impacted in stroke. It's more commonly impacted in conditions like Alzheimer's disease, for example, and some seizure disorders. But typically we don't tend to see, commonly at least, an impact of stroke on storage. And stage 3 is retrieval. So this is getting the information out of the filing cabinet when you need it. This is actually a really effortful process for our brain. So when you think about the amount of things that you've ever learnt and remembered in your life, our frontal lobe basically has to send out a search party to all of those storage areas and all of those little sections of the filing cabinet to find the right information at the right time. So it's got to do a very strategic search, and if anything has happened to your brain, that might become less efficient. Your brain might start looking in the wrong places, or it might take a bit longer to find the right things. This can be impacted by strategy use as well, so there are some strategies we can use to help, and it can be impacted by brain function too, so this is something that can happen in stroke. So like I've briefly mentioned, our frontal lobes in particular are important for that encoding stage, as well as retrieval of information. And our temporal lobe, particularly the hippocampus deep in there, is important for storage. So in terms of stroke as well, just to recap, typically we tend to see that encoding and retrieval are most impacted rather than storage, and that's just based on the anatomical changes that the stroke has caused itself. But there can also be secondary effects of things like mood and fatigue as well on our memory functioning. And again, those sorts of things tend to impact encoding and retrieval as well. All right, so on to the good stuff, strategies and tips and tricks, and at the end I do also have a lot of suggested resources as well, so today is just a bit of a taster, but if this is something you're interested in, definitely have a look at the resources I've got at the end too. So first and foremost, before embarking on any strategy use or any changes to what you're doing, I think it's important to make sure that you are organising your strategies. And it's important to make sure that we plan the strategies we're using and we have a clear idea of what strategies we want to use for what types of tasks. And we want to make sure that we don't have too much overlap as well. So I like using this very simple document. You can make something similar yourself, just draw up a table. Basically in the left, we've just got a list of things that you need to remember. So that's going to be highly individualised, but just have a think about literally every single little thing that you need to remember. It doesn't matter how small or how big it is, but if it's something that you do need to remember and you might sometimes forget, it's good to have it on there. It's good to then have a think about the strategies that you are currently using and fill them all in and whether or not those are effective. If they are effective, that's great, it just stays as it is. If they're not effective, that's where you use the last column to try and brainstorm why they're breaking down and why they're not working and what sort of strategies you might be able to use instead. So this is a living document over time, and it might change when you try new strategies out or when your circumstances change as well. We also want to make sure that we are setting our brains up for optimal performance before we even get stuck into any strategies. So we want to make sure that our physical environment is optimal for paying attention and encoding information. So things like noise and distractions, we want to make sure we get rid of if we know we need to focus. Having it all organised, having a set place for items can really reduce the cognitive load. Even things like the temperature of the room can impact how well we're paying attention. So for men, I believe on average, the best temperature for focusing is 21 degrees Celsius, and for women it's 23 degrees Celsius. So even those sorts of things that you would never think of can impact how well we're taking information in. Planning your day as well is very important, so particularly working in that fatigue management and pacing yourself. We want to make sure that if we do have important tasks that you're going to need to remember later on, that you're planning those things for when you are going to be most alert. And making sure also afterwards that you don't have too many cognitively demanding things afterwards that might exacerbate your fatigue further. Allowing ample time to process information is very important as well as just taking care of your brain health more generally. So we all know that things like exercise, getting enough sleep, eating well, that those things are good for us, but they're also very good for our brain. So our brain uses around 20% of our body's energy, even though it only takes up about 2% of our body's weight. So we do need to be fueling it really well. We do also know that cardiovascular exercise, at least 3 times a week for 30 minutes, can actually promote the growth of new brain cells in the hippocampus, which is important for storage. And that's basically the only thing you can do to grow those new brain cells, and really the only part of the brain that we do get those new brain cells growing in. So exercise, as long as you've got your heart rate up a little bit, moderate intensity, is ideal for that. And as always, just consult with your medical team before starting any new exercise programs or anything like that to find something that's safe and effective for you. So, onto the strategies. When we talk about memory strategies, there's 2 different types we can use. There's internal memory strategies and external memory strategies. Internal memory strategies are things that you do inside your own head. External memory strategies are basically a backup brain, so things outside of us, like a phone, diary, those sorts of things. So in terms of internal strategies that can be particularly helpful, one of the key principles is something called chunking or clustering. So thinking back to encoding, we do have limits on how much information we can take in at once. For a healthy brain that's had nothing happen to it, that's around 7 things, plus or minus 2, so between 5 and 9. If anything has happened to your brain, it's likely that that amount of items that you can take in and process all at once is probably a bit lower, or it might fluctuate day to day depending on how you're going that day. So a good sort of cheat to get around that is to reduce the amount of overarching categories or chunks of information that you need to remember. So for example, looking at this shopping list on the left, there's a lot of stuff there. If you just needed to remember all of that, that's probably going to be quite difficult. But on the right, what we've done is we've chunked that into 4 different groups. So rather than needing to remember the 12 items or however many it is there, we just need to remember 4. So frozen foods, dairy, bakery, fruits and vegetables. And by grouping those things together and remembering those overarching categories, that will then help prompt your memory for the things within each of those categories. So as much as possible, trying to group things together and making it meaningful chunks, that's going to help you encode that information and then also retrieve it later on. Association is also extremely important. So when our brain takes in information, let's say taking in this conversation now, your brain isn't just taking in what I'm saying, it's taking in all of the contextual details as well. It's taking in the temperature of the room, where you're sitting, how you're feeling, if you're tired, all those sorts of details. Your brain is taking in those details and they're attaching them to the memory of what I'm saying right now as well. So we can try and capitalise on that process that our brain is already engaging in by trying to make our own associations to encode things more deeply. So let's say you're trying to learn a name. Rather than just trying to take in the name, try and ask the person more details around it. You know, where is your name from? Do you have a nickname? You know, how do you spell it? All those sorts of extra pieces of information are then going to be attached to the memory of their name. And then later on, when our brain needs to retrieve it and send out that search party to find the information, I like to think of it as sort of one of those ball pits with all the plastic balls in it, and like you're sending out a fishing hook and you're trying to latch onto the little ball with the memory you want. So if that memory doesn't have anything attached to it, you haven't created these associations, it's going to be a lot harder for that fishing hook to latch onto just that one ball in the pool of all of the balls in there. But if that ball is attached to all of these other different associations you've made, even if the fishing hook attaches onto one of those other associations, they're all linked together. So if it pulls out that ball, they're all stuck together, so it's going to bring it all out with it. You might find the association first, and it might still take you a moment to find, you know, the actual name that you're looking for, but since it is all linked, it'll make that process much faster for your brain. So linking things to new information, linking things to information you already know, thinking about any associations, what you can see, hear, how you're feeling, all those sorts of things can make that memory a lot more rich, essentially. Repetition. So repetition is something that I'm sure we all have realised helps our memory, and if we just hear or do something once, it's going to be a lot more difficult to remember it later on compared to if we do it several times. But there are a few things we can do to make repetition even more effective. One really helpful thing is rhyming, trying to make up rhymes or songs. When you think about, you know, adverts on TV and jingles and things like that, we probably remember phone numbers for, you know, Lubemobile and things like that that we've never really processed that deeply or thought about, but they still stick in our heads because of that rhyme and because of the pattern of the jingle. So when we put something in a rhyme or a song, that gives our brain structure for that information, which helps to cue what's coming next. It's also engaging more parts of the brain, so to do with you know, the music processing itself and rhythms and things like that. So again, that's a richer memory. So as much as possible, trying to turn things into rhymes, making up your own songs to remember things. It sounds a bit silly, but it does definitely help. Quizzing yourself as well. So rather than just trying to remember things, ask yourself questions. So this is a process of active retrieval. If you're trying to remember something for, an exam, for example, if anyone's studying, try to quiz yourself first before then checking your notes and going through with checking anything that you've missed. Staggered rehearsal or spaced retrieval is another name for it, is also very important. So rather than trying to repeat something all at once, all in one go, and sort of cramming that information, having breaks between repetitions is very helpful as well. So let's say I do this exercise in one of my memory groups often, and I get people to read 2 paragraphs of information. One of them they just read once, 3 times in a row, and one we practice 3 times throughout the session. Both of those paragraphs we've just seen 3 times, but the difference is how much we've spaced it out. And without fail, people will always say they can't remember anything about the first one, but they do remember at least some details from that second one. So even though the number of repetitions is the same, allowing your brain to have that break and start processing the information and then bringing it back up and adding to it is going to be much more effective. This is particularly effective if you sleep between those repetitions as well. So we do know that sleeping increases our storage of information, and while we're sleeping, our brain is working on all of that information to store it more effectively. So they've done studies where they get groups of people to learn a list of words and 8 hours later test them both to see how many they remember. One group sleeps for 8 hours, the other stays awake, and even though the information is identical and the amount of time is identical, the people who have slept always remember more. So trying to space things out and sleep on it as well. Using context, so this can be helpful at the other end of the process, so for retrieval as well. So like I said earlier, your brains aren't just taking in what I'm saying now, they're taking in all of the contextual details as well. So they've actually done studies to show that if you learn a list of words when your feet are wet, and if you try and remember them when your feet are wet also, you're going to remember more information than if you learn it when your feet are wet and then you try and remember it when your feet are dry. Even just a tiny contextual cue, like your feet being wet, is going to impact how well we can retrieve that information. Even things like the music you're listening to, if you listen to the same type of music when you learn something compared to when you try and retrieve it later on, that will help. Again, studying for exams, if you can study in the same room as the exam, that will help too. So we're not always going to be in a position to physically transport us back to the context where we initially learn information, but we can mentally try and put ourselves back in that context, and that is still very effective. So if you're trying to remember something that's happened, let's say you're trying to remember a phone call that you had yesterday and it's just not coming to you, you can ask yourself these contextual questions to try and jog your memory. So where were you when you received the phone call? Were you at home? Were you in the garden? Were you out for a walk? When was it? Was it in the morning? Was it nighttime? What was it about? Was it about a doctor's appointment? Was it about something that needs to be done around the house? How were you feeling? Was it good news, bad news, just something neutral? So trying to jog your memory and ask yourself all of these questions about the context can be very effective. We've probably all experienced that sensation where you walk into a room and you have no idea why you're there, and as soon as you walk back out, you go, oh yeah, that's what I was doing. And that is exactly what is happening in your brain. Your brain goes back to that initial context where you initially had that thought and that intention, and that helps your brain to find that information of what it was that you were actually doing. Thank you. So external memory aids, like I said, these are things that we do outside of ourselves. I'm not going to go through this in a lot of depth, but I do want to point out some things that we might not always think about. So we've probably all been told, use a diary, use your phone, but it's often a bit more difficult than that. It's not quite as simple. In terms of using phones, something that I do hear very often is that people forget to charge their phones, so it's not very useful as an external aid if it's not working. You can buy battery cases which have extra battery that your phone can use, or power banks as well, so those are really helpful. installing tracking apps like Find My iPhone or a Tile system. So if you just Google Tile, it will come up. And if you've lost your phone, then that will help you to find it, because if you use another device that's linked, it will make your phone start beeping. And just more generally, if you don't know how to use your phone, there's lots of YouTube videos. They're fantastic. Like I said earlier, I'm terrible with technology, but there's excellent videos that can help with this. There's also a lot of community options for free classes run through councils. So if that's something you think would be helpful, I would definitely recommend looking into that. In terms of specific apps, I've got some listed on the slides. I'm not sure if everyone received the slides. They don't. Perfect. Good. So you can have a look through these, but some particular tips. It's a really good idea to try and link as many of these functions as possible. So consider apps that, for example, can link audio recordings to your calendar. So if you've got an important doctor's appointment and you said something really important and you asked to audio record it, link that to the actual calendar event so that you can find it easily when you're looking back. So linking things, thinking things, and trying to use some of these all-in-one apps rather than learning how to use a whole bunch of separate ones is really useful. In terms of medications as well, I know I'm running out of time, but I do want to point out a few really helpful apps as well. The ones, I think I've only got one listed on the slide actually, but there's the Chemist Warehouse app, the Dosecast app, and MediSafe Pill Reminder as well. So those not only include notifications to take your medications, they can also include reminders to refill your script. You can also, on the Chemist Warehouse one, just press a button so that it's filled by the time you get to the store. And the Dosecast app in particular, it will keep going off the alarm until you have actually marked off that you've taken your medication. Another big issue is that people will say their alarm goes off while they're busy. They'll go, oh yeah, I'll do that in a second, turn the alarm off, never come back to it because it's just completely slipped out of our minds. So having functions like this where the alarm doesn't stop coming up for you until you've actually told the app, yes, I've taken my medication, can be helpful. Even more helpful, but quite expensive, so depends on your needs, are these electronic pill boxes. Not only can they remind you to take your medications, but they can also send text messages, emails, and automated phone calls to a family member or a carer as well if you haven't responded to those notifications yourself in a certain amount of time. It's also obviously going to make it a lot easier to check if you have taken your medications already, which can be tricky as well. So if you are interested in those, Tab Timer, I've got the name down the bottom there. Some of those are covered by the NDIS. So just some additional resources, health professionals, a lot of great books and websites there. For stroke survivors and family members, these books are also excellent. And I would also recommend, there is a program called the Making the Most of Your Memory program. It's been validated, both face-to-face versions and telehealth for people with stroke. There are a lot of public hospital units that do run this, as well as a lot of private practitioners, and there's just been a new online version of this being rolled out as well. So speak to your GP or health professionals about potentially trying to get a referral to one of the clinics offering this, because that basically goes through everything I've just whizzed through in a 6-week format with homework and opportunities to practice things and test things out as well. So that's a wonderful program, and I definitely recommend looking into that if memory is something that you'd like to work on.
We actually just have a few minutes for questions, so would anybody like to pose a question to Chiara about any of the issues that you may be struggling with in terms of memory? I guess one of the issues that often come into play, particularly with stroke survivors as well, is the fact that as we get older, memory is impacted as well. And often with stroke survivors, there's a time and place where the stroke issues and the age issues start to integrate, I guess. So my question really is, how do we, as we get older, if we have a stroke in our older age, how do we know that the issues, or can we know that the issues of our memory are part of a stroke or part of just the ageing process?
That's an excellent question, and at the risk of sort of self-promotion, I guess the answer would be a neuropsychological assessment. So what our assessments do, some of the tests we use, we know that they're not impacted by basically any form of brain damage or acquired injury, so they give us a benchmark of where you should be performing and what sort of scores you should be getting on our tests. So if any of your performances are significantly below that, that gives us a good indication that that specific weakness is because of the stroke or an acquired brain injury, because we're also comparing where you should be falling in relation to other people of your age and educational background as well. So that gives us an idea of whether or not memory changes are age-related and normal and to be expected, or if they're beyond that and because of the stroke. So it is quite difficult sometimes to get a neuropsych assessment. There's not many of us, and there's not many positions for us either, unfortunately. But there are quite a few public hospital clinics in the area around here. There's also private practitioners if you can afford it, and the Macquarie University Psychology Clinic also offer subsidised assessments as well for a lower fee. So if that's a concern in terms of teasing apart what's going on for you, that would be the most effective way of figuring it out.
I have to say, those of you who know me and those of you who have been part of committees that I'm on are very much aware that part of the issues for the association has always been that neuropsych has a higher profile, particularly for people who may just go into hospital very, very quickly, having had what they call a small stroke and then sent home. Because often those cognitive issues and the memory issues that you're talking about don't necessarily show up until people are living back in their community and trying to negotiate their world in their environment again. Because when we're in a hospital system, we're often very cocooned and people are making decisions for us and telling us how to behave. But going home is when they often become an issue. Would you like to make a comment on that?
Yeah, no, I completely agree with that, and it's, yeah, exactly what I've observed a lot in the hospital. You're not really needing to take your brain for a test run for too many complex things a lot of the time, and then when you do get home and start to challenge yourself and get back to everyday life, which is a lot more complicated than what you're doing in the hospital, that's when things can start to show up. Again, though, if you are being followed up by a neurology team or neurosurgery team, a rehab specialist at your local hospital, ask them about options. I presume most people would be followed up for at least a few weeks, but if you do fall through the cracks, which can often happen unfortunately as well, ask your GP for options, or if you have a look at the Australian Psychological Society website, there's a Find a Psychologist feature, so you can search by area of practice, so make sure you click clinical neuropsychology and that will come up with options near you as well.
We have a question online.
Yep.
So from one question online, just like to thank you first for your great presentation. And then they ask, what is the most common types of memory loss that stroke survivors experience?
So that generally, I mean, it is, since there is so much variability, it's tricky to pinpoint, but we do see that most people have strokes in the left middle cerebral artery, so that's going to be primarily affecting things like verbal learning and verbal memory. So we do tend to see that memory for conversations, things that have been said, things that you've read can be most difficult to remember, but also due to that fatigue, sometimes slow processing speed, all those sorts of things, just general lapses and forgetting to do things in the future, like taking your medication or going to appointments, those sorts of things can be quite common too because of all of those other factors feeding into memory as well, but generally more of that verbal memory.
Just time for one last question, if anybody has a question in the room. No? We have one online.
So we have a question from Christine. I've had a stroke that affected my brain only and affected the veins in my brain, but the disease I have will lead to dementia. Have you dealt with many other brain diseases such as CADASIL?
I actually haven't seen any CADASIL patients myself because it is quite rare, but it is definitely something that, you know, it falls under that more general neurodegenerative processes. I can't, I guess, answer anything specifically about CADASIL, having not seen it, but there probably are some good resources online. I can have a look and follow up if Christine wants to flick me an email. Happy to chat further.
Well, that brings us to the end of the morning session, and I'd particularly like to thank you, Chiara, for her excellent presentation. It's often an issue that we get questioned about all the time, and often one of those issues too that gets missed as we're going through our stroke journey in both the hospitals and the rehab centres. And I guess that whole issue of lack of neuropsych is a real issue that maybe we need to put some effort into advocating for going forward. So thank you very much today, Chiara, for an excellent presentation. And would you mind joining with me in just thanking her, please?